Hospital Limited, and her topic is Treating Young Minds, the Role of Radiotherapy in Pediatric CNS Malignancies. And it is the last presentation of today's session.
Respected Chairman, dear audience, Assalamu alaikum and very good morning to all. Today I am going to talk about treating young mind, the role of radiotherapy in pediatric CNS malignancies. In this presentation, I will give an overview, epidemiology of pediatric CNS malignancy, most common types of pediatric CNS and their incident rates. Next, I will discuss about role of radiotherapy and common techniques used for radiation, and then I will give a brief review of RT planning process and most common challenges in pediatric radiation treatment, such as need of the sedation and to minimize the radiation dose to control the long-term side effect, and at last, radiation-associated toxicities and importance of the long-term follow-up. On an average, pediatric CNS malignancy accounts 20 to 25%. The main exact cause remains the unknown, and around 2 to 5% are linked with genetic predisposition like neurofibromatosis type 1, tuberous sclerosis, adenomatous polyposis, and Lee-Frommel syndrome. Exposure to ionizing radiation, either diagnostic or therapeutic, considered as a risk factor for pediatric CNS malignancies. Pediatric CNS malignancies is the second most common solid tumors in children. 5 per lakh children annually diagnosed as pediatric CNS tumor. Most common up to the 15 years is incidence rate 26%, and after that it becomes 14%. And most common types are mostly glial tumors up to 14 years, and after that pituitary tumors has the highest incidence, 32.8%. Pediatric CNS include highly medulloblastoma, and peak age is 3 to 8 years, and where radiation plays an important role. And after that, ependymoma, which is peak age less than 5 years. We used also radiotherapy here. Low-grade glioma can diagnose at any age, but usually did not require any radiation treatment unless otherwise it's recurrent or residual tumor. High-grade glial carcinoma diagnosed in adolescent age, and there is an also role of radiation, and ATRT usually diagnosed less than 3 years, so we have some limitation due to age. Pediatric CNS tumor involves multimodal treatment, and it involves surgery, radiotherapy, chemotherapy, and in recent years, targeted therapy, immunotherapy have emerged role in this section. In recent area, molecularly targeted agents, including BRAF inhibitors for BRAF V600E mutation for low-grade glioma, and MEK inhibitors like selumetinib has an emerging role in pediatric CNS malignancy tumor. Immunotherapy is another exciting area, including checkpoint inhibitor and vaccine-based or CAR T-cell therapy are still undergoing in clinical trials. Move towards the precision medicine guided by molecular and genomic profiling, tailored the child treatment for specifically each child depending upon their tumor biology. And finally, supporting and rehabilitation care plays an important role for improving the quality of life and managing long-term side effects. Radiotherapy can be used as a curative intent in case of medulloblastoma and ependymoma. It has also role in adjuvant setting following subtotal resection or high-risk factors, and used in palliative settings, high-grade glioma or recurrent tumor, usually delayed or avoided less than 3 years due to neurotoxicity. Radiation can be delivered in a conventional 2D technique. In our country, it's also practiced due to resource limitation, and we usually use 3D conformal technique and IMRT and VMAT. There is another option, SRSS SRT, which delivered very high dose, very precise radiation, usually 5 gray per fraction, using linear accelerator or gamma knife. We have the linear accelerator facilities, but don't have the gamma knife facilities. And it is mainly used for brain tumors, low-grade glioma or benign tumor, and also used in treatment of residual disease and recurrent tumor. The main advantage of the SRT or SRS is to minimize dose, limited dose to the brain tissue, which ultimately reduce the late side effect and improve along with the excellent local tumor control. There are some general consideration during planning the radiation of an pediatric children, pediatric cases, where there is an age of the child and the tumor location histology and extent of the surgical resection, molecularly subgrouping, especially in case of medulloblastoma, and there is also a neurocognitive impact. So in child, radiation can be delayed by using chemotherapy, and we prefer using focal radiotherapy rather than in extended field radiotherapy. Daily anesthesia and better immobilization helps to reduce planning target volume, but sometimes we use to larger field size if the children is an uncooperative. And use of image-based treatment like 3D CRT and IMRT, and we use smaller fraction whenever it's appropriate. This is the critical chart of the RT process when a patient is planned for radiotherapy, and after proper counseling and explaining all the acute and long-term side effects of the radiotherapy, patient is sent for CT simulation and the image taking and all the image sent to our TPS and the target delineation, and then they are sent to the planning, and child is started the radiotherapy, and we usually do every weekly follow-up, and pediatric child need and appropriate long-term follow-up. And during follow-up, in every week, we have considered to the treatment monitor to the complication, and most common complications in case of CNS tumor is nausea and vomiting, anorexia, weight loss, and including the myelosuppression. That is an important role of oral care if we treated the patient the CSI. So long-term side effect includes the neurocognitive and neurophysiological dysfunction, endocrine abnormalities, and hormonal imbalance, growth retardation, especially in case of the spine. Other potential toxicities include ototoxicity, especially when used the platinum-based chemotherapy, gonadal toxicity, reduced fertility, and there is an increased risk of second malignancy, like meningioma. So if the children is less than 3 years, we delay the radiotherapy by using the chemotherapy as a breeze, and for advanced radiation technique like IMRT, VMAT, or proton therapy has an important role, though it's not available in our country currently. Hopefully it will be available in future, which allows us to precise dose and field modulation. And finally, neurocognitive surveillance has an important role, and accessibility of the rehabilitation for the long-term follow-up care and toxicities. This is the scenario of our hospital, that is a United Hospital. Last 5 years, the most common case is the astrocytoma, glioma, and ependymoma. This is the some pictures that we treated in our hospital. This is the astrocytoma, medulloblastoma, and the ependymoma. So there are several changes in case of treating the pediatric patients because the childs are more susceptible to radiation therapy, which leads them to prone more common in the long-term side effects. They have the radiation therapy has an impact in the growth, including height and other organ function. Radiotherapy impacts on endocrine system, which regulates the hormone. And there is a fertility issue, especially in the growing children. And she gains a children task is very difficult during imaging and the treatment, especially when they're suffering from pain. So pediatric imaging protocol requires and specific trained expertise, and the sedation is a challenging thing in our settings because all the hospital don't have the anesthetic team available. Though I am lucky that I have the all facilities, the anesthetic department in my hospital. So what is the most common challenges in Bangladesh perspectives? In our country, most of the cases are diagnosed late and in advanced cases. So insufficient infrastructures and technology, modern radiation facilities are not available in our public settings, but currently maybe NICHS adopt their new machines. and a shortage of the trained personnel and subspecialty service, the treatment abundant and incomplete courses due to financial constraint, because in pediatric cases we try to use the modern technique like VMAT or IMRT, which is a cost maintaining treatment, and all the treatments are accessible in our center, like Dhaka, other the periphery rural other cities in Bangladesh, not available all the facilities, and especially pediatric concern is immobilization, sedation, and long-term consequences. In a lack of national protocol data and registries as specific to pediatric radiotherapy. So positioning and immobilization and planning treatment is an important goal for pediatric precision radiotherapy, which ensured the CT scan, the entire target volume, full extent of the organ at risk, and a prior imaging should be incorporated with the previous imaging. Now, at the last, I want to share some pictures in the National Institute of Oncology in Hungary. They precisely organize the pediatric treatment they are preparing some gift box for the pediatric patients, which includes some carton box, and there is some toy delivery treatment room, and the immobilization mask become very much attractive, so which they are hand paintings, and they are CT simulator room, and the treatment delivery systems are carton and laser. Hopefully, inshallah, we'll do in our country in future. And at the end of the day, the radiation fighters, pediatric cases received a medal for their completions of the radiotherapy. So in my conclusion, radiation remains a cornerstone in malignancy in many pediatric CNS tumor. Balancing efficacy and long-term toxicity is the key. Technological advances and molecular profiling are shaping our futures. Thank you for patience of hearing.
Thank you so much, Dr. Sadeka Sultana Ahmed, for your excellent deliberation. Now the hall is open for question and answer session.